Okay, let's continue on the smoking. It's not a nice cigar. Unfortunately, it's something that's more toxic, and it's so important today that today there are at least three webinars on surgical smoke contemporary. One in Europe, one in South America, and these two in Asia. About so thanks Fritz, thanks Herbie for supporting this webinar and also for supporting the surgeon with your wonderful technology. Let's see why it's so important. I think it's like intubation for the anesthetist. I think nothing can be done in surgery without use of energy. It is quite time consuming and maybe boring to do any surgery without the aging device. And when we talk about surgery, we talk about heat. And if we look at how the surgery works, we just practically destructure, desiccate, vaporize the tissue. And the different energy work at different temperature. Higher the temperature, more carbon. And if you look at the success and defeat, it means pro and cons of energy, we can see how the energy not only create issues, but create good things like hemostasis, like ablation, like sealing vessel, help us in cutting, but are responsible of the two major injury inside OR, that are OR fire and producing of surgical smoke. Surgical smoke that are toxic. They produce a toxic compound because we are using high temperature and from benzene, formaldehyde, and are very harmful for all the OR stuff. How they are harmful? Because they produce this toxin, can be inhaled, can be spread through bioaerosol, and not only in terms of dead cell material, but also in terms of bacteria, and of course today in the pandemic also virus. So if you look at some surgical smoke we produce when we burn, when you give an item for 1 gram of tissue, is equivalent to smoking 6 cigarettes in 15 minutes. So sometimes the nice smell of barbecue when we are in our OT is not that great and that healthy. So that's why I always been, since long time, in favor of using a filter and smoke evacuation and to be implemented, not only for the virus, but just for our health. And when the COVID-19 virus spread up, I think most of the company come up with a lot of rule and regulation without any background. And then they start look at the aerosolization back from the cancer experience, and they start to ban laparoscopic surgery from being used. And this is the College of Surgeons, the intercollegiate guideline that was published, I think, late in March this year. But then I think more studies come up, and we know more about the virus. We know that the size of the virus. We know that the virus has been found not only in the nasal swab, but even in the gastrointestinal tract. So for digestive surgeons are very important, and even in the peritoneal fluid. So at the beginning, we always were thinking that only the respiratory tract was in danger, but I think at the same time also abdominal cavity and membrane carry the virus. That is normal because it's spread inside our body. And you should consider that symptomatic patients are very low percentage of the positive patient. So there's a capability, especially for COVID-19, to transmit the virus in asymptomatic, through asymptomatic patient. This is much more important. And testing today is slightly better than when it was 2, 3, 4 months ago, but it still have some limitation of false negative. So we should always consider that all the patients are positive, and we should use concentration. We should use precaution, and I saw one of the questions, they were asking about the difference between monopolar, bipolar, that will be in terms of tangible to the one persona. All the energy that we use produce surgical smoke. There is no one energy that's safe, like ultrasonic or bipolar or high frequency or so on. So any energy that use high temperature produce smoke and produce aerosolization and can spread the virus. So of course, in laparoscopic surgery, the risk is higher because we work in the confinement and then we use a CO2, carbon dioxide, for the pneumoperitoneum. And we have the stopcock, the valve, the trocar that sometimes we use to evacuate when the view is not clear because of the surgical smoke. So combining all these factors and combining what is available today and what was actually the best way to capture the virus, we know that HEPA filter can remove, but ULPA filter are much better in terms of removing ultra low particulate filter up to 99.9%, almost 100%, with a size of 0.05. Much more effective than HEPA filter. HEPA filter still work, but in a little bit lower percentage. And if we consider the size of the virus, that is between 0.6 and 0.14 micron, I think ULPA are the filter that should be utilized. What we use usually in the laparoscopic surgery is mostly we have a so-called passive filter and active filter. Of course, the passive filter are low cost, but they are less effective and they get clogged very easily. So for this, we use mostly active smoke evacuators that can be regulated with a percentage of filtration and power to avoid to suck all the intraabdominal pneumoperitoneum. So we should connect all the tubing to the stopcock of the valve and avoid any gas leakage. This is the IS3 that we use, and it can be used also for open surgery. I think Sabrina will talk about it. So laparoscopic reduce for sure the exposure to smoke because it's a closed circuit. If we use all the precaution, so the gas goes in and goes out through a closed circuit, while for open surgery spread around the environment. And but we need to be sure that we use a smoke evacuation device that and filter in a proper way. So the recommendation, as Asim already said, and show for avoid and reduce the risk of smoke in someone, we need to use an operating theater with a positive pressure with the HEPA filter and air circulation. Avoid gas leakage around the trocar. So means when we do the cutting and the incision of the wound should be minimal to reduce the leaking around the trocar, or in case we can do a push string. We should use the lowest carbon dioxide insufflation pressure because of course if we create an intra-abdominal pressure very high, they can leak even more. And we need to use a UPLA filtration device, active device like a IS3, and we need to connect all the trocar valves to the smoke evacuation device. And it's very important that when we end the procedure, we don't remove the specimen until all the CO2 is evacuated through the trocar. So until that we don't remove, we remove the specimen also only after the gas evacuation. And as another further precaution should be, we should avoid drainage because still there is a residual gas inside the abdominal cavity can be spread, or we use a closed suction drainage. Be safe and be healthy. And I conclude my presentation now. And I think we will pass the virtual microphone to Sabrina.